Very touching, very inspiring. Congrats, Norman. Before the formal launch, I would like to invite Norman's wife. If you're on, if you could kindly come on video briefly. We just want to acknowledge you for all the support that you provided to get the book ready. We cannot just say that this is something done by Norman. So as many as you as can, if you could just give her the virtual clap using your annotate function, or you want to come on camera briefly to give the clap. Congratulations to you and Norman, and we look forward to much more of these insightful books that will help shape up the healthcare delivery system. So that said, Doc, I'd like to come back to you for the official launch of the book, and then we take the snipers and the discussions from there. Back to you, Doc.
All right, Fred, thank you very much for the work done so far. Let me congratulate Dr. Norma once again, and then let me thank Mrs. Dr. Norman for the support. Yes, it's a long time I've seen her, so I'm happy seeing her on Zoom. Before I do the official launch, let me also say that the 70-year man who died, coincidentally, I was among the first core team that really did a fact-finding cause of why he died. And I was leading the team. In fact, we visited all the 7 hospitals, and then we got to know that there's a fundamental and systemic problem within our health institutions. And it's very unfortunate that we are still grappling with this problem. So it's really a big issue that, as stated by Dr. Norman in his book, there are a number of things that we need to be doing to address the problem. So having said that, I want to say that to the glory of God and for the improvement of our Ghana's health system, I officially, can we show the book on the screen, please? Fred, can you show us the book, the front page or the cover page?
Yes.
Good. So, like I said, to the glory of God and for the improvement of Ghana's health system, I officially and virtually launched this book that is titled A Developing Country's Health System Challenges, Addressing Ghana's No Bed Syndrome, duly launched in the name of the Father and of the Son and of the Holy Spirit. Amen.
Amen, Doc. Thank you so much. Thank you, everyone. If we could all give some virtual applause for Doc, for Norman, and for all the efforts, for those of us who can come on. Putting together such a well-researched book is no mean feat. And we want to congratulate Norman and Mrs. Once again for the awesome work. And we all look forward to grabbing copies of the book from Amazon, and later Norman will let us know from which other sources but just to whet a bit of your appetite, we have some snapshots from the book I would like to share with you. Some of the critical discussions that the author has picked up in the book that we can run through quickly before we get our panelists for their comments, and then come back to you through the chat room to look at some of the comments that are coming in. So in chapter 2, critically focusing on health financing, the author states that as someone who has run my own health facilities, most private health providers depend on Ghana's NHIA reimbursements for almost all their expenditure, including paying staff infrastructure development, and making a profit at the end of the day. And this was quite sustainable when Ghana's NHIA reimbursements were regular and timely. A lot of private facilities grew and employed several nurses, doctors, and other health professionals. Ghana's NHIA reimbursements account for over 80% of the income of private health facilities in Ghana. My question, why can't the government-owned Christian Health Association of Ghana or mission hospitals and quasi-government-owned facilities in Ghana pay their own workers and run facilities with their reimbursements like those in the private sector? Compared to those who operate private facilities, these publicly funded facilities get the government of Ghana paying salaries, renovating and building new facilities, supplying equipment, and providing human resources. So what do these various organizations do with the NHIA reimbursements given them for work done, which is the main income for private facilities? I guess that is food for thought. Do they make profits? What do they do with their profits, if any? This is an area that needs auditing and accountability, as it leaves room for potential corruption and mismanagement. The author also zooms in on the issue of capitation. And he writes, capitation is a provider payment system in which health providers are typically paid in advance at a predetermined fixed rate to provide a defined set of services for each client for a fixed period. The providers are paid irrespective of any service provision during the designated period. The fixed amount paid for a health capitation system is typically paid on a per member per month basis. Under the capitation health payment system, the member or subscriber selects a preferred primary provider, to provide all the services under the capitation basket in exchange for the capitation rate. Capitation as a health provider payment method has been used in several countries across the economic divide. The UK's National Health Service has used capitation for decades. Now, the UK's health system requires all patients to register with a general practitioner who will refer them, if needed, to other facilities. Thailand has a well-established capitation provider payment system with very good coverage for her citizens and reserves payment methods such as drug-related grouping for higher referral level. Chile and Estonia have also successfully used the capitation system as one of their provider payment methods and have been successful in attaining universal or near universal coverage with health insurance. Currently, a lot of patients shop around local facilities, and a number of them end up with the same medications being prescribed, thus causing waste. Whilst practicing in Ghana, the author notes, I saw many instances when patients came to the consulting room with different brands of the same medicine from different health facilities. The challenges of capitation when it was piloted in Ghana have to be addressed. The author also focuses on human resources in chapter 5. Now, government of Ghana says there's a surplus of nurses and intends to send nurses trained with taxpayers' money to other countries. Ghana's health minister, Honorable Kweku Agyeman-Manu, has suggested that Ghana appear to be overproducing nurses, according to the author. According to him, the minister, from the look of things, the country is reaching a point where it is having more than enough nurses. The minister said that although Ghana's one nurse to 839 population ratio exceeds the World Health Organization's recommended nurse to population ratio of 1 to 1,000, Ghana continues to produce nurses as the 85 nursing and midwifery training institutions graduate an average of 14,000 nurses annually. The writer continues to say that in the UK, a single nurse cares for an average of 9 patients on a medical ward and 11 on an elderly care ward. Research shows that even this number is found to put patients at risk and is the biggest reason for adverse patient events. A survey of nursing staff in the UK in March 2013 found only 31% reported having enough staff. 76.8% reported not having enough time to care for patients. 19.7% said conditions in their hospitals were like those at Mid-Staffordshire. And the Francis report showed the role low staffing plays in poor patient care. Research by nursing academics, according to the author, shows the maximum number of patients that a nurse can effectively and safely care for is 4. However, a Ghanaian nurse takes care of an average of 22 patients. The author continues talking about human resources by saying that the government of Ghana committed 232 million for the payment of nursing trainees allowances for the 2017-2018 academic year. Cancellation of the nursing trainee allowance will save Ghana 232 million cedis, the equivalent of $41.4 million. Government of Ghana, in the author's opinion, should use this money to recruit and retain more nurses. This, he says, could be crucial in negotiating its abolition due to political ramifications. An interesting point there. Food for thought once again. Nursing trainees should have access to student loans like others do in the tertiary sector, according to the author. He continues to write that I recently applied to several institutions in Ghana to be employed and to relocate. It took 3 years and a few interviews before an offer letter was tabled. I believe there are a lot of Ghanaians and other diaspora doctors and nurses who want to relocate and share their experiences and knowledge in Ghana. These people, like him, the author, are not doing it for the money, as they are paid considerably more in developed countries. However, they would want to be paid a reasonable amount or at the same level as other professionals of their caliber are paid in Ghana. This remuneration can either cater to their day-to-day needs in Ghana so they can use their savings to build, buy houses, or live comfortably back home. An interesting discussion on how to get some of our healthcare professionals relocating home. Maybe the last one, and then I get back to the panelists for their views. The author continues to say, these professionals, I believe, also seek to be in a situation where they can contribute to real changes on the ground. The author proposes that Ghana introduce a diasporan healthcare visa that will allow highly specialized doctors, nurses, and other professionals to be employed in Ghana. Ghana can have a quota every year to employ such highly skilled people, especially in areas that are lacking. This will be a reverse brain drain, as some of her citizens have acquired highly specialized and needed skills in various developed countries. There must also be a focus on the transfer of skills to health professionals at the local level when they can take up such jobs in Ghana. On ICT and information technology, the author writes that patients needing transfers to bigger hospitals could potentially be reviewed daily by a specialist many miles away to prevent unnecessary referrals and congestion at such sites. For instance, a neurologist in Accra can take care of a patient in the northern part of Ghana without that patient necessarily taking up bed space in Accra. Interesting thought. Now, through digitalization, Ghana can triage more efficiently and make better use of her bed space. I believe that there are a lot more nuggets hidden in the book, and I would want to encourage each one of us. Norman will come on again to tell us where we can find copies, to reach out there, get a copy for ourselves, get a copy for people as presents, and I believe that our thoughts will be quite stimulated on the issue of no bed syndrome and the other challenges facing healthcare delivery in Ghana. At this stage, I would like to turn on to our panelists. I'll go first to Dr. Lawrence Osei-Tutu. Doc, if you're on, would like to hear your thoughts after reflecting on this book and the reasons for which it is written. Based on your own experience, what reflections would you like to share with us on this subject matter?
All right, thank you very much. So, congratulations to Norman once again. We have in a way been close. He was my roommate, and he's always been the smarter one and academically oriented, unlike me. He has his own ways of looking at things. And he's never shy to, express contrary views, and for that, I think it comes through the book, at least from the snippets what he sent to me that I read, mainly concerning, if you like, the human resource part or the human resource parts, the nursing parts, the ratios and all that. It is interesting, the comments. I'll try not to, I believe, as academic that he is, he has thoroughly researched all that is written and provided adequate references. So I will not try to, go into much of the other side of it, but I'm sure other people currently in the management space within our healthcare service would also have something to say about all that is written. And that is a good thing, right? Because it will stimulate some kind of discussion. Having said that, we discuss too much in Ghana. That's my problem. So if you watch the clip, the problem was, or the challenges this family faced had nothing to do with beds. It had everything to do with human beings. And you really do not need to be like a super specialist bed manager trained somewhere else outside Ghana to fix that problem. All you need is for Ghana to have its way of doing its own things. But unfortunately, we are confused. So you have somebody trained in UK like Norman, who comes on board with these brilliant ideas from UK, wanting to just pick it from UK and come and bring it to Ghana. Like me, trained in South Africa, Cape Town. This is what we do in Cape Town, so this is what I'm going to do in Ghana. Somebody trained in Germany and said, this is what I'm going to. Nobody has studied the Ghana situation, situated into the Ghana context, and say, I went to study what they did in the advanced world. How do I practically implement something that works well for my people? And that has always been the biggest challenge. So we just train, we love degrees, and we pay people. The more degrees you have, the higher your salary. So you can stay out of work, get about 1,000 degrees, and that is how you get more money, right? So the person comes back and he has no practice, zero knowledge of what is actually happening. So my point is that there are people sitting at the top, managing these so-called facilities. They do not even know patient flow within their own hospitals. I can tell you there are heads of the department who do not know what is happening in their own units because their headships are in their offices. They don't know how things are run on the ground. And that is how our health is going down. You see, when I used to teach medical students in Kumasi, I would ask a group I see all the time, tell me how many of you truly wanted to be medical doctors, and that is why you are here, slaving away your youthful days in School of Medicine. You wouldn't get more than 10% of a cohort at a time. They are there because their parents were doctors. They said they should become doctors. They are there because they were smart enough to get good grades. They are there because their parents were rich to pay fees for them. And that cuts across. I haven't done any survey in the other side of nursing, and I'm sure you find the same reasons cutting across. So we are picking people right from the beginning who do not even want to be there. And so they are frustrated in the first place. So the next, they are always finding a way out. I always challenge them and say, if you want to be a rich person, why be in a job where you spend 8 to 10 hours sitting at one place, earning a salary? Your colleague who has a laptop is earning more. So it is the human factor which is running us down. And my opinion on the no-birth syndrome has always been that the challenge, it has nothing to do with beds. We have adequate facilities. This gentleman moves through 7 facilities. He's blessed. In Ashanti region, he wouldn't get three facilities to move through, right? But in Greater Accra, he had the opportunity to do that. And you could see, I haven't seen the report, that clearly it's a human factor. So even if you had no bed, what patient were you dealing with before the person got to you? Or were you even informed that the person was coming? And so on and so forth. So there are simple things we can fix. It does not need like studying some wild system elsewhere, but fixing it the Ghana way, doing the Ghana thing, and not trying to bring in some kind of ideas that has, yes, worked, that's evidence-based, but how do you apply it? That's no do gap. That gap is so wide. There's so much we know as a people, but there's so little that we do. So the gap keeps widening every day. And that is the crux of our problems. The consultant who attends to patients only once a week, his subordinates who cannot take decisions because the consultant hasn't seen the patient, the subordinate who cannot think on his feet and innovate to see that, where is my patient coming from? Can this patient receive this blood transfusion at his or her local facility so that I can free space, time, resources, and other personnel in my facility, and he can be comfortable in his home? It's just a blood transfusion. Many facilities can do it. Why admit this patient to a very expensive bed in a tertiary center to do that when the patient is stable? But you need guidance. You need somebody to hold your hands to think like that. And that someone is on the books, he's there. He's a fantastic, well-read person, big professor, highly published and all that, but practically he's absent. So there's no guidance for the younger one. So we have turned ourselves into robots. So every day he goes to the wards, he writes problems, he documents the problems, and he just, let me wait for someone to come and solve the problem. So we are fantastic at documenting problems, but we are not solution oriented. And that is the thing. So we are training the same thing. So we are pumping money into training nurses. But I'm sure if you ask those paying for the training, listen, what was your plan in the beginning? How many general nurses did you plan to train 10 years ago? Have you reached your target? I'm not sure anybody in Ghana can answer that question. I doubt there's anybody in Ghana who can answer how many geriatric physicians that we need in Ghana. Nobody can answer that question. How many pediatricians do we need? How many oncologists do we need? Nobody can answer that question. And then they just sit there, a paper comes in front of them, I want to go for training. Oh, who is your father? Oh, I know your father. Go for the training and come back. He comes back, super specialist, nothing to work with, and he's wasted, all right? So that has been our problem, and I hope this book, once we read on, will also touch on some of these issues and stimulate some of these discussions. My friend, Dino, congratulations once again, all the best. And I will be the first person to finish the whole book. I don't like reading, but for your sake, I'll read this book. All right, man.
Thank you, Oti.
Thank you so much, Lawrence. Thank you, Dr. Setutu. But whilst you are on, interesting thoughts in the chat room as well. So Sam shares some thoughts, and he says, Lawrence is spot on, but I understand that the need for situated or localized evidence-based practice. But surely the good aspects of systems in other countries can be trialed and adapted in Ghana if shown to be workable. He continues to say that the human factor applies everywhere and the problems can often be similar regardless of the country. I wouldn't have thought that Ghana's healthcare problems are so unique that our human resource problems can't be solved through lessons from other countries. I think that is the whole idea of the book, to generate discussion, to stimulate our thoughts. And what I take from Dr. Osei too is that, yes, sometimes we discuss too much and we never get to taking the bold, pragmatic actions that are required to bring the needed change in the health service delivery system. Thank you so much, Lawrence, for sharing with us. Dr. Adoma, I come to you next. You have a wealth of experience in pediatric care, kangaroo care and all that. I got to learn about kangaroo care when I had twins who were preterm. And I found it exciting and very interesting to see. From what you have seen over the years in your practice, what are your thoughts? What do you want to share with us regarding the whole challenge of healthcare delivery and the specific issues that Norman is raising in this book?
Okay, so thank you so much for the opportunity and my greetings to Honorable Chairperson. Good to see you again. So I would like to comment on two aspects of the book. One had to do with the emergency care, and then the other has to do with the health IT and then infrastructure. So let me start with the health IT and infrastructure part. I realized from the book that Norman brings up interesting things. You know, when it comes to the issue of telemedicine, currently, there is telemedicine going on, but at a lower scale, not a large scale, as Norman is suggesting. Sometimes not really advanced telemedicine, but then you end up helping a person somewhere to manage a case. So say the kid is in Boko and it's a very critically ill child. Then the nurse there, because she knows you, she calls you and says, what should I do? Then you guide her as to what to do. She's able to keep the baby there, or the medical officer is able to keep the baby there, stabilize the baby, and eventually discharge the baby. So this is what we are doing on a low-key level. But Norman is saying that we should take it to the higher level, and we should make it part and parcel of the healthcare system, even such that NHIS reimbursements will cater for this. And this is interesting because he raises the point that currently the reimbursements or the claims is normally related to the physical structure. So I and Hope Exchange, physical structure, we submit our stuff. Let's say a district hospital which doesn't have a specialist, so it hasn't been given that level of credentialing to prescribe certain medications. They are only able to submit certain claims on certain diseases. But what Norman is saying that district hospital should be able to engage a specialist in another part of the country. That specialist sees people over whatever media they want to use, treats the person, and that person doesn't need to move through the system to the teaching hospital to go and hog up the beds there. So that's what he's saying. But then he brings up the point that then what will health insurance say? Is health insurance going to reimburse this person? Because you don't have the credentials to treat that patient, but you have liaised with a specialist to be able to treat that patient. So who pays for it? Or does the patient pay out of pocket for this? Will the patient pay out of pocket for this? Will the media, you know, when we ask patients to pay money, you know what happens in the media goes crazy on us. BNI will descend on your facility. So will the media, will the patients accept all this? But it's something that if we really want to free up beds in certain places is one of the things that we can do. Not all critically ill patients, not all patients need to be moved to the teaching hospitals, etc. Sometimes the specialists need to go out, need to go down there, or we need to use the the health information technology. And he also brings up the issue of, you know, having a seamless system such that if there's a patient who lives in Wale Wale and he's come to Kumasi to do something and he has an accident or he falls critically ill, I should be able to see this patient, get access to this patient's folder without having to wait for days, do new tests and find out what the patient had or what he was being treated for in Wale Wale. I realized that things have been put in place, and I think that Dr. Chair will be able to correct me. But I know that things are in place for us to have that seamless system. But we like things to be done faster than at the rate at which it's going. Because what happens currently is that you will have to, if you know somebody there, or what we do now is, I'll put it on, say, let's say Lady Doctor's page. Does anybody know a doctor in Wale Wale? Then somebody will backstage me. Oh, yes, this doctor is in Wale Wale. Then I'll call her and say, oh, and there's this patient who is in your facility. He doesn't have his OPD card on him. Is it possible for you to be able to trace, find out from his records what he has been treated for before in your facility? And it's difficult. But if there's that seamless system, then at the click of a button, I'm able to have access to all the patient's records. And you know that a lot of our patients, we have a lot of patients who are illiterate. And even among our patients who are literate, our diagnoses are huge. These diagnoses, sometimes you can't even keep them in your mind. And for a patient to be walking around having his diagnosis in mind, he probably may not have it. So if we're not able to have access to the patient's information wherever we are, then that is also one of the reasons why patients will spend long in the hospital and then hog up the space. The other time when this whole no bed issue came up, I think it came up again last year when Honorable Sam George lost the son of a friend. This issue came up again. And I read a point from Lawrence Otis, a write-up that he did. And in that, he talked about the role of the specialists and the senior doctors in contributing to this. He mentioned it again today, that sometimes you have somebody who comes once in a week. So we are just reviewing the patient, continue treatment, till that senior specialist is able to come on Friday and comes and says, oh, this patient, there's nothing that we can do, send him home. He has hogged up the bed for 5 good days. Have we ever sat down to quantify and see if beds are hogged up in the teaching hospital, how much does it cost us per day? How much are we losing? And that's one of the things that Norman brings up. If we actually quantify how much we lose, the cost, sometimes it may make our managers sit up and be more, let me use the word proactive, more proactive in getting the system to work, getting the consultants to come in, not just once a day. If your contract says you are to come in once a day, then that's different. But if your contract says you are to come in every single day of the week and then do ward rounds and then review patients, then it will help us move the system. Patients will be moved on faster, and then we can end up getting them to go home faster. Let me just make another point about the health IT thing. I think you brought up a brilliant idea, and I don't know how far it's already being put into practice, but it's about having a dashboard available that shows you, remember during the COVID time, you could click on a map of Ghana and then you could see where the hotspots were, where there were the COVID cases, so that if you're planning some travels, you know which places to avoid and then which places to go to. It would be brilliant if we had that dashboard of hospital beds available, the kind of hospital beds available. So we have 3 ICU beds available in this facility, 10 available in this facility. So when any patient is being referred or things like that, even the ambulance service, and Maxwell is high up in the ambulance service, and I'm sure he will speak to it. The ambulance service is able to tell us, okay, we can send a patient to this facility because there are beds there. What we have to do currently, and it slows down things and it makes patients become more ill and they end up spending more days later. What we have to do now is that I will call maybe one facility. If I know somebody there already, then it's easier getting things done. And I guess that's one of the reasons why, like Oti was saying, every family wants to have a doctor in it, so that at least when there's an emergency, your doctor will know somebody who will sort you out. It shouldn't be that way. The system should work for everybody, including the vulnerable tomato farmer who knows nobody. The system should work for everybody. So what happens is that I will have to call, and then maybe I'll call a facility, and then I'll ask, do you have beds available for this kind of condition? And then they'll say, oh, no, we don't have beds available. Then I'll have to call another facility. If I already know the people, then I have access to their numbers and it's easy to do. But if I'm a junior doctor and I don't have access to these people's numbers, I can't call them one-on-one and find out. And I have to go through the system, go through the interchange and this and that. They'll tell you to hold on for hours and you'll be listening to that boring song that they always play when you're supposed to hold on. And it takes so much time and it worsens things. One thing that has to do with the infrastructure also is that we need to strengthen the periphery, and it comes out brilliantly in his book. We need to strengthen the periphery. Let me give you a case. I'm a pediatrician, so let me give you a case and this is my last point, involving a small baby. So let's say that this baby has neonatal jaundice. He's become yellow, but the district hospital where he attends his clinic, they don't have a phototherapy there. So he goes there and then he has to be referred to another facility that has a phototherapy. The referral costs money. The referral is not as easy as you think. You don't just get up and go. Sometimes relatives want to know, who do we know there? How do we get the money to go, and this and that. So finally, he ends up at the referral facility, by which time the illness has become more severe. Now, simple phototherapy is not going to work. Now he will need an exchange transfusion. At this facility, they don't know how to do exchange transfusion. So the first facility didn't have the equipment. This one doesn't have the skill. So now they have to go to Kolebu. They have to come to Komfanachi before they get the exchange transfusion done. This could have easily been prevented if the first one had the phototherapy, if the second one had the skill. Now this baby, who did not need the exchange in the beginning, has now worsened because he has had to go through the system in a way that he shouldn't have. And he's worsened, and now he's hogging up a bed in Kolebu Niku, where a tiny preterm who has been born, maybe 0.5, 0.6 kilos, little piece of a baby, needs an ICU bed, and then the place is full. All because this baby, who we could have seen and managed in the district, we didn't have the skill, we didn't have the equipment, therefore he's bumped up through the system, and now he's hogging up a bed. So Norman, your book is brilliant, and I can't wait to read it through from beginning to end, probably with a bottle of Coke, some ice cubes, and some kebab to go with it.
Thank you, Adam. Thank you.
Thank you so much, Dr. Domas. Very, very interesting insights there. I hear you say, yes, ICT efforts are happening. They should move faster. And the state of technology, we should bring that to bear in our healthcare delivery system. We should stop hogging up beds in the hospital. Specialists, if they need to be there daily, need to be there. So people who have to go home can go home and free hospital beds. And yes, of course, we need to improve responses in the district facilities and all, so that cases do not worsen and end up in the referral centers to pick up spaces, especially for children as well, so that preterms and all can get the needed attention. Interesting insights there. Ladies and gentlemen, we still have some time on our hands. We are happy to open the floor to take comments and feedback from participants. If you wish to do so, kindly put up your hand using the annotate function, and I'll give you the opportunity. A point that was made, let's let the system work for all of us. You don't need to know people. I have a personal experience. My mom wasn't well a couple of years back, and I remember I had to call on all the Prempeh College doctors I know. I see Dr. Chris Opong on the call now. Chris, you're welcome. I had to chase him from everywhere to the ends of the world to make sure that I was getting the right attention for my mom. Can we move away from that and make the system work for everybody? I guess Norman's book comes up with some insights on what needs to be done and what ideas could be tested. So I see your hand up. Is it Dr. Maxwell Osampoku? Kindly unmute and make your points. Hello, can you hear us? Hello? Maxwell, if you're speaking, we cannot hear you. Maybe if you have a connection problem, you could drop your thoughts in the chat. Okay. Hello? It seems your connection is poor. Could you drop your thought in the chat box for us? Yes, you sound a little distant. If you could adjust the volume. Unfortunately, I think we lost Maxwell. So like